to see many of you again. So nice to really talk with some of you, not on email, and meet in the flesh for the first time. So I'm not just gonna wax on poetically about what's going on at the NIH. I really wanted to focus more today on some of the evolution in our thinking about how to approach the liver in DADA2. And so let's just step back and talk about what we have kind of observed in the first 10 years or so, in that we've well established that patients with DADA2 can have big livers, big spleens, they can have portal hypertension, and we know that they can have abnormal liver biopsies. And we're gonna look more at that here in a couple slides. And that over the course of time, we've also seen that the liver can be quite finicky when it comes to a transplant. Meaning that we've had patients who've had VOD, veno-occlusive disease. We've had patients where we didn't realize they had some baseline disease liver who didn't tolerate the conditioning very well. So live and learn. We do that every day with this disease. But historically, we've been recommending, and even so much, we put a lot of this in the consensus statement, is that you get an annual transient elastography or FibroScan, which measures how stiff the liver is. And then also annual ultrasounds with Dopplers to try to look at the flow. And in the patients who are going to be referred for transplant, I would recommend that you strongly consider getting a baseline liver biopsy in them so that you're not on the flip side saying, gosh, I really wish we'd done that ahead of time. Look at the mess we're in now. And these are pictures we all know and love. A really big spleen and a little girl, at the time she went on TNF inhibition. We've seen up to 20 centimeter spleen span. Here we have her dilated vessels, and then the backward flow through the umbilical artery. We've also seen that we can have esophageal varices when we've done endoscopy. And on prior biopsies, we'd seen that you could have sinusoidal dilation, as seen right here with these black arrows that you can see in a lot of inflammatory conditions. We've also seen small portal veins, which sometimes become less ability to open when you've got increased pressure going through. And then one of the hallmark things we see on the liver biopsies is this aberrant staining of sinusoidal endothelial cells. You use the CD34 stain for the endothelial cells there. And in a typical blood vessel going through the liver, it's fenestrated. So that stain all kind of diffuses out and you don't see it. But in the diseased DADA2 vessels, it's not able to get out. And so you see that staining, as you can see, going along here along the vessels. On biopsy, we've had patients be diagnosed with nodular regenerative hyperplasia, focal nodular hyperplasia, and hepatoportal sclerosis, just among others. So a couple years back, Dr. Theo Heller, who's the hepatologist at NIH, who sees all of our DADA2 patients, said, let's have coffee. I said, okay. And he said, we need to kind of rethink the way we're going about this. He goes, there's been a kind of a change in the way we're thinking about things in the hepatology world. Because transient elastography or FibroScan is really great in picking up cirrhotic disease. But in DADA2, very often we're dealing with more of a non-cirrhotic portal hypertension picture. So chances are you might not have an elevated FibroScan number. And if you do, boy, you might be really up a creek without a paddle because the disease has probably gone on for quite some time by the time you would get to that point. So he said the nomenclature has changed in the hepatology world, and what we used to call non-cirrhotic portal hypertension, when you've got that in the context of patients who have these baseline inflammatory diseases such as nodular regenerative hyperplasia, the hepatoportal sclerosis, and portal hypertension, we now call it portal sinusoidal vascular disorder. And in these patients, instead of getting the annual FibroScan, he says, I think it would be much better if you look at their spleen and if it's going to enlarge, and also is their platelet count trending downward. And if you've got a combination of the two, you really need to put into your head that you need to consider whether or not there's worsening liver disease. I said, okay. That's great. And I said, okay, I'm going to put this to the test, because I knew that we had 3 patients in our cohort who we had documented had portal hypertension. So I said, I'm going to go back and I'm going to look and see what their lab showed, what their spleen size showed, and we're going to see if this is going to hold true, and if we can start talking like this may be a good idea. So first we have a 26-year-old who has a known history of portal hypertension. And as you can see, at the time she was getting ready to start on TNF inhibition, she was thrombocytopenic with 89,000. Her spleen size was enlarged, around 15 centimeters. She was right on the cusp of having an abnormal transient elastography, but it was just, wouldn't have been noteworthy to us. It wouldn't have necessarily prompted us to say, oh boy, we really got to look at this. But we went ahead and we had done, we did wedge pressures on her and found that she had a markedly elevated portosystemic gradient, normal being less than 5, hers was a 15 to 16. So quite significant portal hypertension. And then, as you can see, I put this just so you can see the comparison. After she's been on TNF inhibition for about 9 years, her platelet count has gone up to 150,000, and her spleen size has shrunk some, and her transient elastography has come down. We did, like I said, do a biopsy on her, and we found that she had periportal and perisinusoidal fibrosis with some mild chronic inflammatory infiltrate around the portal areas. She was missing, and we're going to talk some more about this a little bit later, missing and had abnormally shaped portal veins, and then that aberrant CD34 staining of the sinusoidal endothelial cells. So there you had first patient who we knew had it. Now we had a 17-year-old who wasn't 17 at the time, is 17 now, but at the time she went on TNF inhibition, you can see again, thrombocytopenic with big spleen, really big spleen when she was younger. She was one of our first patients, and we weren't even doing FibroScans regularly then, so we didn't have one to report. But when we did her pressures, we found again that she had very elevated pressures on her biopsy. And that post-TNF inhibitor, fast forward about a decade, you can see too her platelet count has gone up to 220,000, spleen size has come down. But, and this will also come back into play, we can see she has these variable FibroScan results. And we're gonna hit on this a little bit later. But at the time when we first were seeing her and evaluating, she had a liver biopsy which showed these small slit-like portal veins with a little bit of inflammation and some sinusoidal dilation, and again the aberrant staining of the endothelial cells on CD34 staining. We had diagnosed her with hepatoportal sclerosis at the time. Lastly, we have a 35-year-old who came to us pre-TNF inhibitor with a thrombocytopenia again, a really, really big spleen, and a very low transient elastography number. But she was not very well off because she actually had esophageal varices that had bled, and she required some banding. So we knew she had mega problems, and she actually had to undergo distal splenorenal shunting in April 2015. Her biopsy, back when we were first seeing her, showed the perisinusoidal fibrosis with some inflammation and the CD34 stain. And again, we made the diagnosis of a hepatoportal sclerosis in her. So just a quick summary of these 3 established patients pre-TNF inhibition. These patients all had portal hypertension. They had the decreasing platelet count, the increased spleen size that I remarked upon, and the liver biopsies that showed the hypertension. And then they also all had abnormal pathology on liver biopsies. And notably, 2 of the 3 patients had normal transient elastography at the time when we were evaluating them. And post-TNF inhibition, you did note that all 3 had improvement in their platelet count and decreasing spleen size. So let's just talk about the hepatic imaging evolution though, because there were some, the one girl kept having these variable transient elastography values again. And in the patient who had undergone the distal splenorenal shunt, it was recommended that we keep getting MRIs of the abdomen on her every 6 months just to evaluate, see how the shunt is doing, see how her liver looks. And over the course of like 8 years, she started developing multiple liver lesions that we thought, okay, I think this is the well-established NRH that we see in DATA 2. And also a little FNH in there as well. But it continued to grow. And so earlier this year, we looked at our follow-up and said, okay, this is 8.2 centimeters now. And that's quite large, as you can see right there. This is slowly overtaking her liver. I think we can't just sit back and continue to watch because it's getting bigger. Even if it is a benign thing, we gotta get in there, we gotta biopsy, and we've gotta see what's going on. So we did a liver biopsy, and as you can see, she had absent portal areas, and the buzz phrase here is that she had these unpaired arteries, which is right here, seen with this blue arrow. And these are, I didn't realize this, but these are apparently very concerning. You might see these as patients are transforming over to like a hepatocellular carcinoma. So we were initially like very caught off guard by this and concerned for this patient who's very dear to us. And then we also saw that she had focal areas of hemorrhage, as you see right here, and inflammation right here, this infiltrate, right, these cells. And so in summary, Dr. David Kleiner, who was here yesterday, but I don't think he's here today, sent this off for further review with some other pathologists who are very good at reading liver biopsies. And the meeting of the minds came back showing that they felt that it best fit with the inflammatory subtype of hepatocellular adenoma, although it had those nefarious features of the unpaired arteries. And so they were saying there is always that probability that you could have that transformation to hepatocellular carcinoma. So we said, okay, well, we're not going to sit, we're not going to wait, we're going to put her for hepatic embolization of the mass, and we did that in June of this year, and we just had follow-up imaging last month, and we did see a significant reduction in volume by about 35 to 40%. But our plan for now is to have her repeat the embolization in the next 2 to 3 months. And the end goal, per Dr. Heller, is that we're going to get it small enough to where we can do an ethanol injection and kind of obliterate it. So why does this even matter? Because that's an N of 1. Well, again, I went back and looked at these other 2 patients that I had talked to you about earlier. And in the first patient, we had her get an MRI of the abdomen, and it showed multiple T2 enhancing masses that were suggestive of an inflammatory process that have developed over time, despite having a normal fibroscan. And on radiology review, they felt that it was very consistent with adenomas, the way it's coming and going sometimes, and some are a little bit bigger than others. And then in the other patient, we haven't been able to see her back yet, but I went back over a CT of the abdomen that was done a year or so ago, and that was for another reason, and found that she also had multiple arterial phase hyperenhancing nodules that have developed in her liver. So based upon the fact that we're seeing this and that maybe our routine recommendation for ultrasound isn't quite sensitive enough, especially to pick up these smaller lesions. And these lesions could also, I think, explain away her variable FibroScan results, because if you're checking an area that has a lesion versus checking an area that doesn't, you could see different numbers that you get back. We're recommending, at least in our cohort, that as we see them, we're just going to try to establish baseline MRI of the abdomen, looking at the liver, just to see if we see any lesions. So we're not caught off guard again. So in summary, 11 years after our original publication, our appreciation of all that is DATA 2 continues to evolve. I think that's the take-home message of this entire meeting. Monitoring of platelet count and spleen size may be more sensitive than transient elastography for looking for portosinusoidal vascular disorder. These inflammatory hepatic adenomas can develop with atypical characteristics, such as the impaired arteries, and we have one case of partial reduction with transarterial embolization of the lesion. Baseline MRI of the abdomen to further assess for hepatic lesions may be considered for patients, and I do still recommend the annual ultrasound with Doppler to assess for the portal flow. And with that, that's a wrap.
All right, well, thank you very much, Mandy. Are there comments or questions with regard to this presentation? Ivona.
I have a question. I think you want to the microphone.
Yes, use the microphone, please.
Yeah, there are remote participants that I think are.
So my question is, how specific these findings are really for DADA2 compared to other patients with, monogenic autoinflammatory diseases in our cohort and other cohorts as well? First thing comes to my mind is that I do know we had a couple of patients with HAT20, and I just don't remember what was found on histology in HAT20 patients and their liver problems, compared to patients with DADA2. And then my second question is just, if I understood correctly, I mean, despite the treatment with anti-TNF therapies, their liver disease sort of still progressed, maybe at a lower rate. So what about doing some workup, immunostaining of these liver biopsies to see what's happening with, not just the cells, but also with cytokines? Maybe, liver pathogenesis is driven by another cytokine, possibly.
I think that's a great idea, and we haven't really done that, but I think that's a really good idea, so that I answered the second part of your question first. But in regards to, yes, inflammatory conditions, we definitely see like nodular regenerative hyperplasia and focal nodular hyperplasia, but we don't see these adenomas. That is what is different. So we chalked this up to being NRH for years, and it was only because it kept growing and growing that we really said, let's make sure that that's what it is. And that's when we found out we were wrong. And that was just, a gut punch there, that we'd just been monitoring these for every 6 months on scans. And so, yes, we see these NRH and FNH a lot across the board in autoinflammatory disease. Well, maybe not a lot, but definitely multiple cases of it. But these adenomas that are more of an inflammatory subtype are exceedingly rare, in my experience.
So maybe there should be also an effort on the level of the society to collect information about the liver disease in patients, throughout the world, and see, what findings are really more significant in this disease.
I agree with that. I think that the liver is often a missed part of this disease as far as all the things that can go on with it. People focus on the bone marrow and they focus on the strokes and the inflammatory features that we see, but the liver can be a really quiet player.
Okay, other comments or questions?
So adding on to the 3 patients that Dr. Umbrello eloquently described, there is a 4th patient that we just saw in clinic who was evaluated by our hepatologist, Dr. Heller, and her FibroScan, she's 17 years of age, she has DADA2. Her FibroScan was completely normal, and her spleen size is 18 centimeters, and her platelets are like 78,000. So she's coming back in a month or so for a MRI of the abdomen and a liver biopsy and an upper and lower scope to rule out if she has varices and portal hypertension. So that would be the 4th one.
And at least from what we heard from Dr. Umbrello, it sounds like, at least on TNF inhibition, the prognosis would be that the platelet counts would come up and the spleen size would go down, but the jury is out with regard to what would happen with these other manifestations.
Right. And it does take time too. Like, those were increases over the course of like 5 to 10 years, so.
Okay.
Thank you.
Thank you very much.